Good morning, everyone. Thank you for joining us for today's Grand Rounds. I have the honor of introducing our guest speaker for today. Dr. G.R. Scott Budinger is the Ernest S. Bazley Professor of Airway Diseases and the Chief of Pulmonary and Critical Care Medicine at the Northwestern University Feinberg School of Medicine. He also serves as the director of the Simpson Querry Lung Institute for Translational Science. His work focuses on the intersection of basic science and clinical medicine, specifically in the areas of lung injury repair and the application of advanced genomic technologies in pulmonary disease. We're so honored to have him join us, and we look forward to this excellent talk.
Thank you. Thank you, everybody, for being here, and thanks to everybody on Zoom as well. It's really a great privilege to be here and to be speaking of in the presence of Dr. Roy Weiss. Many of you may not know that when I was an intern at the University of Chicago, Roy Weiss was my chief resident. So I have a bit of a feeling of actually, presenting at Morning Report and having the imposter syndrome in front of my chief resident and trying to do a good job. So thank you all for being here, and I really look forward to the visit. I also want to take a moment to actually talk to all of you that are training right now. This is a difficult time to be thinking about a career in academics and academic medicine for lots of reasons, but it's also, I think, the best time to be doing it. When Roy and I were residents, and we were actually in the intensive care unit, I had about 10% of our ICU population was asthmatics, right? And we were treating asthma with, I'm not joking, 20 to 40 puffs of beclomethasone a day, because that's all we had, right? And right now, I think we see maybe one patient when I'm rounding in the ICU with asthma in a year. Right, and it's just huge progress. And if you think about that, if we think about interstitial lung disease that we're going to talk about a little bit today, we had 0 therapies, now we have 3. You think about diabetes care, we have GLP-1 receptor agonists, we have all kinds of therapies, and all of those result from discovery-based research that's done by people like you that are in this room. So keep up the good fight. I think actually if we want to have new drugs and new therapies for our patients 20, 30 years from now, we have to be doing the science now and putting in the work. So congratulations to all of you that are making that commitment. I have no financial relationships to disclose, and the things that I'm going to talk about will mention during this during the talk. So I want to start off with a case presentation. Actually, I'm going to start off with 3 case presentations, and these are 3 patients that presented during the COVID pandemic. Sorry to give you PTSD, but we actually have 3 patients with these are all men in their 50s, all presented during the first wave of the COVID-19 pandemic. All of these chest x-rays were obtained within the first 5 days of hospital admission, and you see the typical pattern of diffuse bilateral ground glass infiltrates with patchy consolidation and various hardware that's supporting these patients. All of these patients had very long lengths of stay in the ICU. All 3 required ECMO during their hospital course. So all of you remember these patients, and you can actually see these 3 cases on the with the reference numbers there on the publication in JCI from Kathy Gao and in PhysioNet, and all of the clinical data that I'm going to be talking about. What's different about these patients is what happened afterwards. So this is the first patient, and this is 3 months after discharge. You can see this is a CT scan. You see there's an area of organizing pneumonia in the right middle lobe that actually almost completely resolves a year after discharge. So this patient had almost a complete recovery of his lung function. The second patient did okay, got discharged from the intensive care unit, but ended up with bronchiectatic changes and fibrosis in the right middle lobe and the lingula. This patient has, and these persisted 3 years after discharge. This patient continues to have respiratory symptoms and is one of our patients in the clinic, continues to follow us with us in the clinic. And this third patient actually looks like they did really well, but actually this patient did the worst of the 3. This patient went on to develop progressive fibrosis, multiple ventilator-associated pneumonia episodes, and this is his allograft post-discharge. This is his image post-discharge, and he had a bilateral lung transplant for COVID-19. Right, so the question is, what is the difference between these patients? Why is it that case 1 actually got all the way better, and case 3 went on to develop progressive fibrosis that was so severe he needed a lung transplant? So, one possibility that we'll talk about first is actually the idea that actually it's something that happens in the ICU course. So very often as critical care doctors, when we read an article in the New England Journal, right, we look at diagnosis, intervention, outcome, right? Three pieces, right? But actually, we all know that rotate in the ICU, all of us that rotate in the ICU know that it's actually way more complicated than that, right? And I think of this sort of like a game of snakes and ladders. We go in on a day of rounds. We actually take all kinds of information together as a team. We discuss it together. We roll the dice and we pick the best intervention we think that's going to make that patient better. And sometimes we hit a ladder and the patient gets better. Sometimes we hit a snake. We end up with a complication, and those progressive accumulation of complications can lead to poor outcomes in the ICU. So maybe that's the case with these patients. So what we can do then is sort of unravel this ICU case, open up that black box between ICU admission and discharge, and try to see if there are things that are different within the clinical course that might explain the different outcomes that we see in these patients. And this is what Kathy Gao, one of our trainees who was on a K grant at the time that she did this work, and she was actually a fellow when she did this. She now has got a K grant. And her mentor, Rich Wunderink, did. So what Kathy did was she went into the ICU data and unraveled each one of these patients that were in this cohort that we call the Successful Clinical Response in Pneumonia Therapy cohort. This is an NIAID-funded study where we're taking patients with severe pneumonia requiring intubation and studying their clinical course to try to identify pathogenic pathways that are important for disease that might be amenable to intervention. And so if you look at this here on the y-axis, you actually have SOFA score. This is a severity of illness score. And you have on the x-axis the days in the intensive care unit. And you can see all three of these patients were very sick. The latter part of the bottom patient, which had the longest stay, is actually his post-transplant course. But all these patients were very sick. The lines on here I want to note are actually times that these patients had a BAL sample. So in our intensive care unit, when our clinicians suspect that somebody has pneumonia, we perform a bronchoalveolar lavage. That lavage goes to the lab. We get a 33-panel PCR back within a couple of hours. That includes most of the known bacterial pathogens along with antibiotic resistance genes. We get quantitative cultures back within about 48 hours, and we've shown that our clinicians use that information to either expand antibiotic therapy or narrow it, including discontinuation. In patients that consent, and they're in this script trial, an aliquot of that fluid comes to the clinical laboratories for examination. And I want to just bookmark that these BALs are available on all of these patients. But we have actually more than just the SOFA score on each one of these patients. As all of you that rotate in the ICU know, this is a very data-rich environment, and we actually have many, many things that we're collecting either continuously or on a daily basis, and those include things like vital signs, ventilator parameters, laboratory values, the doses of medications that we're using to support the patient, the antibiotics that we're using, et cetera. And what Kathy did was she said, well, we've got all of these parameters. I'm going to pick as many as I can. I'm going to clean those data in all of these patients. And then I'm going to use data science approaches like we use with genomic data and try to actually put like patient days with like patient days. So this is a UMAP plot. And this is just a two-dimensional representation of that 40-dimensional data that you saw on the previous slide. Each dot on this UMAP is a clinical state of that patient. So this is the daily summary of their clinical features. And what we've asked the computer to do is to put like days with like days. And the computer gives us some useful information up here on the left. Let me just see if we can get a dot. Up here on the left, we have ECMO, and you can actually see all the patients going through various states within ECMO. Over here on the right, you have extubation, and this patient actually was censored when they went to transplant, so never was extubated. And then you have clinical states that if you looked at these features, you would actually recognize them as clinicians in the ICU as being, sort of, that's my hypoxemic respiratory failure cluster, that's my shock cluster, et cetera. And now we can start to unravel this ICU course in a more specific way, right? Thinking about the different clinical states that patient went through over the course of their ICU journey and think about whether that might have contributed to their outcomes. And in this paper that Kathy published, she showed the importance of secondary bacterial infection in patients with SARS-CoV-2 pneumonia in determining outcomes. So this is a useful approach. Moreover, this is a way that we can actually start to interpret those BAL samples that we're getting into the laboratory. So remember I told you that each one of those lines on that slide a couple times ago was a BAL sample that was being obtained. We actually get that into the laboratory. We actually are able to do multiple different things with that. I'm going to talk to you today about our work with flow cytometry and single-cell RNA sequencing. This is work that's led by Sasha Misharin in our group and Ben Singer. And these are, I just want to point out that these are actually very sick patients. So this is the disposable bronchoscope we use. This is actually a patient with COVID-19. That's why the picture is taken through the window. The patient is prone, receiving mechanical ventilation when this procedure is being done. And our goal with this project is to actually generate these multi-omic data, integrate them with the clinical data, what Kathy has done, those clinical states, and use that information to try to generate hypotheses. All we can do is generate hypotheses about disease pathogenesis that might be important for the selection of therapies. So during the COVID-19 pandemic, we were able to do this. And I just demonstrate this as proof of principle, but also to just sort of introduce this idea of the alveolar space too. So this is work that was done by Rogan Grant, who at the time that he did this work was a PhD candidate. He now has a Schmidt Fellowship and is writing his K-99. Luisa Morales-Nebrada, who was a pulmonary fellow when she started this, had just received her K grant, now has 2 R01 grants. And Nick Markov, who was a master's student, actually went on to do his PhD and now is in Dana Pear's lab at MSK as a postdoc. And so what three of them did was they used this genomic data that we were generating, primarily single-cell RNA sequencing and flow cytometry, to develop a model of SARS-CoV-2 pneumonia. So here we have a simplified version of the alveolar space, and I've broken it down to just 3 cells to make it easy. And we have here the alveolar type 2 cell. This is a small cuboidal cell that makes surfactant proteins. And it's also a progenitor cell. So it actually, upon injury, it can undergo asymmetric division and generate one of these AT1 cells. These AT1 cells are very, very different. These are very, very thin cells. They're required for gas exchange. And in the mouse, they actually lay like a blanket over 2 or 3 alveolus. Really dramatic change in the cell as it goes from this little tiny cuboidal type 2 cell into a type 1 cell. And these are the cells that line most of the alveolar space. We also have here a tissue-resident macrophage, my favorite cell. We're going to talk a little bit more about macrophages during the talk. SARS-CoV-2 gains access to the alveolar space via droplet aspiration, and it infects cells that express its receptor. That's the ACE2 receptor. The ACE2 receptor expression is limited to alveolar type 2 cells, and it's not very many alveolar type 2 cells. So only about 1 or 2% of alveolar type 2 cells express the ACE2 receptor. So very sparse expression in the distal lung. There's a productive infection in these type 2 cells, and this leads to an increase in the concentration of the virus locally, and that leads to the infection of these tissue-resident macrophages by mechanisms that we still don't understand. They don't express the ACE2 receptor. In response to that infection, these cells release T-cell chemokines, and in addition, although macrophages are generally poor antigen-presenting cells, they can activate cross-reactive T cells in the alveolar space. And we know that even before the pandemic, about 20% of the population had T cells that were cross-reactive to SARS-CoV-2. In response to the interferon gamma from those activated T cells, these macrophages make more T cell chemokines and make more monocyte chemokines. And eventually those cells undergo apoptosis. They are replaced by classical monocytes from the circulation, which differentiate rapidly into these monocyte-derived macrophages. More on those later, so keep those in mind. These monocyte-derived alveolar macrophages express all kinds of inflammatory and profibrotic genes, and they are further activated by the interferon gamma from the activated T cells. They also are susceptible to infection by SARS-CoV-2. And so we end up with this self-sustaining and self-amplifying signaling loop between activated T cells and monocyte-derived macrophages that are recruited to the alveolar space during SARS-CoV-2. And this is all a hypothesis that we put together from the genomic data and from the clinical data. But during the pandemic, we actually had the opportunity to test some of these hypotheses for better or for worse, because as you may remember, there were all kinds of clinical trials that were ongoing with different therapies for patients with SARS-CoV-2 pneumonia during the pandemic. And in fact, we, and I'm sure here as well, had committees where we were actually deciding which of these trials we wanted to participate in. And after we had developed this model, we elected to participate in a trial of this drug called Oxora. This is a drug that inhibits calcium release activated calcium channels, or crack channels. Crack channels are important for T cell function. They may also be important for macrophage cell function, but we know for sure they're important for T cell function because if you have a mutation in the genes for these, you end up with severe combined immunodeficiency syndrome. So this is a cause of SCID in children. And so this drug inhibits the crack channels potently, and we reasoned that it would decrease the inflammatory signaling, at least from the T cells, and maybe also from those monocyte-derived macrophages. So we were really pleased when this study was actually, the results of this phase 2 trial were published. There was a 56% reduction in all-cause mortality at 30 days, 33% at 60 days. And you can see that the survival curves separate very nicely around the time of drug administration. And we continue to do clinical trials with this drug in our intensive care unit. So promising phase 2 trial findings based on this genomic model. And, maybe one of the ways that we can address this question that I had, how do we make more people like case 1 and fewer people like case 3, is to actually give drugs during their ICU stay that do things like prevent ventilator-associated pneumonia, or drugs that intervene on the host immune response to mitigate against the severity of acute lung injury. Moreover, this sort of gives you an idea of a model that we might take forward and apply to other diseases, not just diseases in the ICU, but other lung diseases and other diseases elsewhere. And that is that we can use these rich data sources that we have in the electronic health record, like Kathy had done in extracting the data from the clinical record. We can use these molecular pathology techniques that are evolving very rapidly, and I'm thinking about single-cell RNA sequencing, spatial transcriptomics, spatial metabolomics, spatial proteomics. And we can actually use new and emerging data science tools, including machine learning and AI, to integrate these models and make predictions about interventions that might be effective in mitigating disease. We can then take these data to pharma, right, and we can generate small molecules or use existing small molecules, as we did with the COVID pandemic, causally validate them in mouse models, and then test them in clinical trials. And the beauty of this approach is that because we're doing the clinical trials in our clinical spaces where we generated these hypotheses, the results of the clinical trial, whether positive or negative, will be incorporated into the model. So the next time it makes a prediction, it's going to actually know what the result of that intervention was. And some of these interventions are very specific, right? An IL-6 receptor antagonist like tocilizumab does one thing, right? And so we can actually make some causal inferences about the role of these different pathways in the diseases that we're studying. So I'm going to shift gears a little bit, because when I started doing work in the lab, and way back when, we didn't have the advantage of all this molecular pathology or these data, right? And so we did this. We actually looked at this in a very reductionist approach, and we focused on a cell called the alveolar macrophage. And I already introduced the alveolar macrophage when I talked to you about COVID-19, but here I'm going to give you a little primer on macrophages. So bear with me. Alveolar macrophages are one of the many different tissue-resident macrophage populations that you have in your body. So every organ in your body has its own tissue-resident macrophage population. Every microenvironment in every organ in your body has its own tissue-resident macrophage population. In the alveolar space, we call them tissue-resident alveolar macrophages, right? Not very inventive, right? And these cells are actually very interesting cells. They don't come from the bone marrow by and large. They come from the yolk sac or the fetal liver. They self-renew. If you have a mouse and you keep it in a clean mouse house, you will not get any bone marrow contribution to the alveolar macrophage pool over the lifespan of the mouse. And we know they're important for homeostasis. If you don't have alveolar macrophages because you have no GM-CSF, which is granulocyte monocyte stimulating factor, or you develop an antibody later in life to GM-CSF, you will get a disease called alveolar proteinosis, where you will literally drown in your own surfactant because these macrophages are not clearing the surfactant proteins in the alveolar space. So these are necessary for homeostasis. We think they also interact with stromal cells within the lung to maintain homeostasis, but the evidence for this is less clear. During injury, everything changes. So in response to the injury, a signal goes out from the injured organ, in this case the lung, to recruit classical monocytes from the circulation. These are the monocytes that you measure in your CBC. Those monocytes, by and large, there's another population too, but it's small. These classical monocytes enter the alveolar space where they rapidly differentiate into those monocyte-derived alveolar macrophages. Remember, those were the bad guys I told you about in COVID. These monocyte-derived alveolar macrophages look a whole lot like tissue-resident alveolar macrophages. So even a flow expert like Franco D'Alessio will have a hard time actually distinguishing these in models of lung injury, right? Because they look very similar. But we know from lineage tracing them in mice that if we look at their transcriptional profile, they're very, very different from the tissue-resident cells. They make a lot of inflammatory genes, a lot of fibrotic genes. We also know, because we can do genetic tricks in mice where we selectively delete these cells while leaving these cells intact, that if we make these cells go away, things like bleomycin-induced fibrosis, asbestos-induced fibrosis, influenza, silica, all get better. So we know that this cell is a pathogenic cell population in at least all of those disease models. There's a lot more alveolar macrophages during the injury than there is during homeostasis. And when resolution happens, when you go into that case 1 setting, most of these cells die. They undergo apoptosis. And the niche is reconstituted either by persistence of these monocyte-derived cells in the niche or by the proliferation of the tissue-resident pool. And we have shown that these cells over time become transcriptionally and functionally indistinguishable from one another. So a prediction from that model, and this is was that if we looked at a fibrotic patient, if we looked at the lungs of a patient with pulmonary fibrosis or any other lung injury, we should actually see 2 populations of macrophages at least, right? We should see the tissue-resident population and the monocyte-derived population, just like I showed you on the cartoon. And this is what actually prompted us to do the first single-cell RNA sequencing study in the human lung. This was actually explants from patients with pulmonary fibrosis in our transplant program. And in aqua, you have actually the donor lung, so a biopsy of the donor lung taken at the time of transplant. And in the sort of salmon color, you have patients with pulmonary fibrosis. And if you look here, you can see the shared population of tissue-resident macrophages here. And then down at the bottom of this UMAP plot, you actually see these patients with pulmonary fibrosis. And if we look here, the maturation genes are actually higher expressed in the shared population. And in the monocyte-derived cells, you actually see this fibrotic gene expression. So that's, and you can see the same thing in mice. So if we look at a mouse in a model of asbestos, here we're looking at the alveolar macrophage populations. Here we have the alveolar macrophages, interstitial macrophages. You see this ear here on the alveolar macrophages that's only present in the asbestos-treated animals. Nikita Joshi, who was in the lab at the time, actually noticed that these alveolar macrophages express relatively high amounts of a gene encoding CSF1. Remember, I told you CSF2 is what's required for a tissue-resident alveolar macrophage. CSF1 is required for macrophages in other tissues. And she wondered if she was to inhibit that CSF1 receptor, could she actually make fibrosis better? Because we had shown getting rid of these cells genetically was helpful. And in fact, that was the case. So when she gave a mouse asbestos and then treated it either with an antibody against the CSF1 or a inhibitor, a pharmacologic inhibitor of the CSF1 receptor, she not only actually made the fibrosis stop progressing, but she actually reversed the established fibrosis in the mice. And this actually was proven in humans sort of remarkably last year. So this was a paper that came out in the New England Journal of Medicine. A drug called axatilimab was used in a phase 2 trial to treat patients with refractory graft versus host disease. So these patients actually had to have failed 2 standard of care therapies and have multi-organ fibrosis in order to be enrolled in the trial. And in this trial, there was actually 73% of patients that received the drug had a reversal of established skin and lung fibrosis. So really a remarkable and dramatic finding. This is the only paper that I've ever seen where fibrotic lung disease has been reversed. So this actually, I think, what this tells us is that these monocyte-derived macrophages, those bad guys that I told you about, are in the causal pathway of fibrosis in at least some of our patients, right? Maybe not everybody, but at least if we can find the endotype that responds to this, we maybe have an effective therapeutic. But this poses a problem for the field, right? And the problem is that the genetics actually don't point to macrophages at all. So this is a timeline that was written by Tim Blackwell at Michigan, David Schwartz at Colorado, and many others in the field, just sort of reviewing the studies in familial pulmonary fibrosis and sort of what we've learned over the years about pulmonary fibrosis, where we ended up with patient 3. And if you actually look at the mutations in families that are associated with that, they are largely limited to the epithelium. So if you go back in 2001, surfactant protein C is just expressed by those type 2 cells that I told you about. Surfactant protein A also expressed by the type 2 cells. Telomerase mutations actually have been localized to type 2 cells in mouse models. So the telomerase mutations that are associated with pulmonary fibrosis. And then the most common cause of pulmonary fibrosis, common genetic association with pulmonary fibrosis, the MUC5B mutation, is a gene for an abundantly expressed mucin in the distal airway. So the epithelium seems to be the cell that's actually driving the pulmonary fibrosis, but I just told you the macrophage is in the causal pathway. So how do we actually put this together? And the answer again came from these genomic technologies, which have really been very disruptive. And they've been, and I just want to take a minute and point out sort of how disruptive they've been and how disruptive they've been in relatively small numbers of patients. So this is actually, I told you that we published the first single-cell RNA sequencing study in human lung explants from patients with pulmonary fibrosis. The group at Vanderbilt published another one, and at the same time, the group from Yale published the third. And I just want you to actually look at the number of patients here, right? Which is the important thing is, you know, we're talking about slightly over 100 patients. Nobody thinks we need to do more, right? We think we have actually exhausted this with a very small number of patients. So when you get up close, things look more the same, right? So you can really make distinct or make some conclusions about endotypes from this. And what we learned about the epithelium from these studies was really important. I told you that type 2 cell was a partially committed stem cell population that did an asymmetric division, repopulated the niche, and then went on to become this strange-looking type 1 cell, right? It turns out that as that happens, there's a transitional cell population that forms. So this population has markers of both AT2 cells and type 1 cells, and you never see it in the normal lung, right? In the normal, none of you have you may have a couple, but you have very, very few of these transitional cells. Right? In patients with pulmonary fibrosis, they accumulate and fairly dramatically. They also are present in a brief window during alveolar development. So they're part of a normal process, but they actually you don't see them unless you're diseased. And these cells express all kinds of interesting things like PI1, a gene that's important in fibrosis, like P21 and P16 for those of you that think about senescence. So these are a very interesting cell population that seems to accumulate in the fibrotic lung. So we took these observations and several others, and we came up with an idea about how pulmonary fibrosis might work, how you might end up like patient 3 after an injury. And so this looks complicated, but it's really not. You've seen everything on this slide already, except the fibroblast, okay? So here we have we've taken that same picture that I showed you before, the alveolar type 2 cell, the alveolar type 1 cell, and the tissue-resident macrophage. And now we're going to take that and we're going to injure it. Maybe we're going to injure it with SARS-CoV-2. We can injure it with flu. We can injure it with asbestos, silica, you name it. Or maybe it's a genetic predisposition. That results in a disruption of the alveolar capillary membrane, barrier dysfunction, right, in the alveolar epithelium. And that leads to the recruitment of these classical monocytes, these monocyte-derived macrophages that come in. And we think these are coming in to actually serve a function. We think they're coming in to seal the wound, right? You can't have your lung filling up with fluid. These monocyte-derived macrophages, in the absence of an epithelial barrier, are able to directly interact with fibroblasts in the interstitium. And they release things like PDGF, TGF-beta, and those things drive the proliferation of fibroblasts and promote their secretion of collagen and other matrix proteins. At the same time, there's a competing process of alveolar epithelial repair. So these alveolar type 2 cells divide and start to make these AT1 cells, and in the process form this transitional cell population. If that process is successful, you actually interrupt these interactions between macrophages and fibroblasts. The fibroblasts go back to quiescence, and the macrophages either mature or die off. But if this process is not successful, if this repair fails, these interactions are persistent, and Yuri Alan and Ruslan Medichev at Yale used data from our group and from others to show that these circuits between monocyte-derived macrophages and fibroblasts that are at the beginning of the injury actually become unnecessary. The fibroblasts themselves will make their own trophic factors eventually and lead to progressive fibrosis. So does this have any clinical meaning, right? So you made this great model, and again, you know, can we actually take this to the clinic? And we actually were again able to do this in the COVID-19 pandemic. So this was work that Nick did along with Melissa Query, who is an MSTP student, is now a fellow in our PSTP program. And what they did was that during the pandemic, we had our surgeons come in and do warm autopsies on patients that died in the intensive care unit, took a lung biopsy from the patients. And Nick and Melissa did single-cell RNA sequencing on a small number of those biopsies, and these are actually presented with the first COVID transplant here. And what they did was Nick developed an approach called transfer learning, where he was able to take the single-cell data from the COVID patients and map it onto that Haberman data set, that Vanderbilt data set that I showed you earlier. And what he found was that all of the populations that were present in end-stage lungs that were getting transplanted for traditional indications were present at a molecular level in patients with end-stage COVID-19, including those transitional epithelial cells, the monocyte-derived macrophages that we talked about, and some of the activated fibroblast populations that we haven't talked about. And this was important because at the time, we weren't the only ones thinking about doing COVID-19 transplants, right? It was something that everybody was talking about, but there were two concerns about doing that. The first was, are we going to get SARS-CoV-2 back in the allograft, right? And we had been doing bronchoscopy since the beginning of the pandemic. We had lots and lots of data about viral clearance. We had no concerns about that. But we were concerned about the possibility that maybe these patients that we were saying clinically looked like patient 3 were really patient 1. And if we just waited, they would get better. And we were doing them a disservice by transplanting them. And, these data helped to convince us that that actually was not likely to be the case. And that prompted us to do the first and subsequently about 40 transplants for patients with COVID-19 and led to UNOS approval of COVID-19 as an indication for transplantation. So in the last part of the talk, one other implication from this model is that we should be able to use these monocyte-derived macrophages, the abundance of these monocyte-derived macrophages, as reporters for disease severity. And when we think about trials for patients that we think are going on to progress to fibrosis or who have a diagnosis of pulmonary fibrosis. And we were able to test this in a rheumatic disease that many of you may take care of, scleroderma, right? These are patients that develop multiple organ fibrosis. I will just briefly go through this study that was led by Sasha Misharin and Monique Hinchliffe, a collaborator at Yale, where we did research bronchoscopies on patients with scleroderma ILD. This was 47 patients with scleroderma, 21 healthy controls, and again, applied those single-cell RNA sequencing technologies to this BAL fluid. Here you just see a UMAP with all of the data. And a prediction from that model was actually true. That is, we saw an increase over here in the monocyte-derived alveolar macrophage population in the patients who had scleroderma with ILD compared to patients that had cutaneous limited scleroderma, and a reduction in the tissue-resident macrophage populations. Moreover, the abundance of these monocyte-derived macrophages correlated with pulmonary functions as measured by DLCO and FVC, and with radiology scores of disease severity by CT. So again, perhaps we can actually use these monocyte-derived macrophages as a biomarker of therapy, and perhaps we can actually target them with drugs like CSF1 or other therapies that might target these monocyte-derived macrophages. Moreover, we can actually look at the transcriptional profile here and look for responses to drug. And here we're just looking at the response in the monocyte-derived macrophages to mycophenolate mofetil therapy, which is standard of care for these patients. So looking at this model, we have actually 3 different opportunities for treating these patients, right? We can actually work on promoting epithelial repair, and this is what Franco is doing in his lab, where he's studying regulatory T cells and how regulatory T cells might promote epithelial repair. We can target these monocyte-derived alveolar macrophages, or we can use existing drugs like pirfenidone and nintedanib that we think target fibroblasts, right? And we can imagine a future where we have actually combinations of these different therapies, right? And I'm going to spend the last few minutes of the talk, probably the next 5 minutes or so, talking to you about another strategy that we have to actually improve epithelial repair. And this is work that came from Satoshi Watanabe. Satoshi was a postdoc in our lab. He now has his own laboratory in Japan. And what Satoshi did was he looked again at single-cell RNA sequencing data that was coming from the bleomycin model of fibrosis generated in Germany by our collaborators in Gießen, Herbert Schiller. And he noticed that at the time that these epithelial cells were making transitional cells. At that time of transition, there was an increase in a signal suggesting activation of the integrated stress response. We'll talk about that in a minute, but this is a stress response pathway that's designed to maintain the proteome. And it sort of makes sense. If you're trying to go from a tiny little cuboidal cell into a big, large cell, you're going to want to activate protein protective pathways as you start to activate all of this machinery to make lipids, proteins, et cetera, that you need to go from small to big. And what Satoshi did was he said, well, is that a good or bad thing? And so he treated mice in the bleomycin model with an inhibitor of that integrated stress response. And what he found was that the mice did better. Bleomycin fibrosis got better. He went on to actually do a lineage tracing system where he labeled the type 2 cells. He put a green label on the type 2 cells and said, after I treat them with ISRIB, do I have more or less type 1 cells that are green? And he found that there were more green type 1 cells. So he had accelerated alveolar epithelial repair, and the number of those transitional cells also decreased. So it seemed like this activation of the integrated stress response in the setting of bleomycin-induced fibrosis was pathologic. And that actually informed work that another trainee in our lab, Sung-Hae Han, was doing with my long-term friend and collaborator who was at University of Chicago with Roy as well, Nav Chandel. Nav is interested in mitochondrial signaling, and Tim Blackwell had shown that families with pulmonary fibrosis, one of the mutations they have is actually in complex 1 of the mitochondrial electron transport chain. And so Sung-Hae was modeling that by deleting complex 1 from the alveolar epithelium. So these mice had no mitochondria in the alveolar epithelium, and we thought, well, things will just die, right, without mitochondria, but that wasn't the case. In fact, what happened was that when she took the complex 1 out, the lungs filled up with transitional cells. Just the whole epithelium became a transitional cell. She looked at, in response to Satoshi's work, she looked at the ISR signal on those cells, and it was through the roof. And when she gave that same small molecule inhibitor to these mice in a brief window after birth, so during development, she actually was able to rescue the mice. The mice went on to live with no mitochondria in their epithelium for 2 years, looked completely phenotypically normal. So two drugs that might, so this might be a drug or this inhibiting these stress pathways might be a way that we can improve alveolar epithelial repair. And this has actually since been confirmed in several different genetic models of fibrosis in mice by Mike Beer's group, by David Schwartz's group at Colorado, and by the Hal Chapman's group at the University at UCSF. So I'm gonna take 2 minutes and just show you something that I think is really exciting. This is unpublished data. We've been really, one of the things that's actually limited the field has been, and especially if we start to think about these combination therapies, is the lack of a mouse model. I've told you pretty much everything makes bleomycin better, and so if you give 2 things, you can't make bleomycin much better than it's already been. And so we wondered whether we can actually develop a model, whether this integrated stress response was sufficient to induce pulmonary fibrosis. So I've showed that we can inhibit lots of different pathways and we can make fibrosis better. And I showed you we can inhibit the integrated stress response and we can make it better. But is the integrated stress response in the epithelium sufficient to induce pulmonary fibrosis? So the ISR, this integrated stress response, is activated by one of 4 kinases that phosphorylate an important protein for translation, EIF2 alpha. And this protein, when phosphorylated, can't form a translational initiation complex, so you get a global inhibition of translation. There are some mRNAs that have specific sequences in their 3' UTR, such that their translation is actually enhanced. And one of those is ATF4, which is a transcription factor whose translation goes up upon activation of the ISR. It translocates to the nucleus and it activates a program that involves a lot of metabolic genes that are important for resilience to stress responses. So we made a mouse that actually expresses ATF4 just in the alveolar type 2 cell inducibly. So the mice grow up and then we give them tamoxifen and the ATF4 comes on in the type 2 cell. And remarkably, these mice die in about 6 weeks, and they die from pulmonary fibrosis. So they get progressive pulmonary fibrosis, starts at the periphery, moves centrally. They get hypoxemic. They look very similar to what we see in patients with pulmonary fibrosis. And when we look at them with the single-cell RNA sequencing technology, and I won't go through it here, all of their type 2 cells become transitional cells. And you can see it here with the tamoxifen. This green is the transitional cells. They're down here at the bottom. And very interestingly, they express proteins that are they express genes that are quite interesting. One of them is, for example, GDF15, which is one of the proteins that's actually predictive of progression of interstitial lung abnormalities in humans on proteomic profiling of the serum. An interesting phenotype. And when we look at the score, the genes that are activated in those ATF4 expressing cells, we see that those same genes are activated in human pulmonary fibrosis. This is that single cell data set from the Vanderbilt group. And right here in the middle, these are those transitional cells that they had identified in their study. So this also, you remember our model. Our model says that, well, this activation of the ATF4 should lead to those bad monocyte-derived macrophages coming in, and indeed that's the case. We see these cells being recruited that you can see here, and when we do spatial transcriptomics, we can see that these cells are in the same space as these activated fibroblasts. And I'll just finish with this picture. This is a spatial transcriptomic picture of one of these ATF4 gain-of-function mice. On the right side, we have the normal alveolar epithelium, and here we have these amphiregulin positive AT2 cells. These are the ones that are those transitional cells. We have monocyte-derived macrophages marked by MMP12 in direct contact with those fibroblasts, again suggesting that all of the components that we suggested in our model are actually present in this ATF4 gain-of-function mouse. And this looks very, very similar to a paper that was published in Nature Genetics last year by Nick Banovich and John Kropsky at Vanderbilt, at TGen and Vanderbilt respectively, where they showed that these keratin 17 transitional cells in humans were actually detached from the epithelium, just like we saw with the monocyte-derived macrophages and fibroblasts underneath. So perhaps we have models now of progressive fibrosis where we can start to actually do what I talked about, actually do combination therapies and see if these combination therapies work alone or together to actually ameliorate fibrosis in some of these models. We don't know yet, but I think it's an exciting new time for the field as we sort of explore this. This kind of work takes a lot of people. I've tried to acknowledge the people that contributed to the work through the talk. It also requires a lot of funding from lots of different sources. And so I want to thank all of our funding sources and actually just say that these are team efforts. Those are the authors on that Nature paper that I showed you in COVID-19. All of you are actually contributing to the work that's being done as we care for our patients. So thank you.
Scott, you were brilliant as a resident. You're even more brilliant now, and it's an honor to have listened to this amazing, amazing lecture. Thank you very much. Let me begin by just asking a question, and I don't think you used this word once in your entire grand rounds, and maybe it's my foolishness to think the role of steroids. And, can you enlighten me a little bit as to how it's such controversial? Do we give steroids in certain lung diseases in the ICU or do we not? And is there any insight to that based on the molecular data that you have?
So Roy, thanks for the question and an insightful question. So I think in terms of the acute pneumonia, the first part of the talk that I talked about, that course during the ICU, the effect of steroids is probably pathogen specific, right? And they are beneficial. It's clear from the RECOVER trial that actually in patients with SARS-CoV-2, giving corticosteroids was beneficial, right? In trials that preceded that, in influenza pneumonia, right, they were harmful, right? And the response of the critical care field, and here I am being critical of the critical care field, has been to say, well, we just need larger numbers of patients with these same syndromic definitions. And then we're for sure going to see the benefit of steroids in all kinds of different things. And in fact, what I think is we need to do the exact opposite. We have to be endotyping our patients and figuring out which ones are going to benefit from the steroids and which ones are going to be harmed by the steroids, because we're just seeing a net effect. In terms of the fibrosis space, these monocyte, for a long time, people said inflammation's not involved in pulmonary fibrosis because corticosteroids are harmful. If you actually look in the mouse models, even in bleomycin, steroids have no effect. They actually increase the number of monocyte-derived macrophages that come in. So, I think to think of steroids as targeting all immunity is incorrect, right? Steroids are actually, as you know, Roy, right, are very highly selective drugs, and they need to be used in a targeted way.
Great. Dr. Lakakis online, you have a question. You want to unmute yourself and ask the question?
Thank you. You showed the interferon gamma produced by the T cells.
Okay, in the meantime.
Yeah.
Dr. Franco DeLacy.
Scott, that was fantastic. The monocyte AMs, do you know if they're epigenetically reprogrammed and they have memory phenotype?
Hope so, but no. Franco asked the question: is there epigenetic programming? And I had a program project grant to test that hypothesis, which was wrong. We actually, Franco's asking the question, since we have ontologically distinct populations of macrophages, one coming from the fetal liver yolk sac, another one coming from the bone marrow, are they actually epigenetically distinct, and do they behave differently in response to a secondary inflammatory stimulus? So we had one of our PSDP students, actually, Ale Makwade, had a paper in JCI where she actually did a Herculean experiment where she created a mixed bone marrow chimeras of literally 200 mice and gave them 2 hits. So she gave them a sequential hits of bleomycin and influenza. The first one was to actually get chimerism, so you had some monocyte-derived and some tissue-resident macrophages in the same niche. And then the second one was to see if that response was different, which would be the prediction. Absolutely the same. And we went as far as actually doing, Ben's methylation signatures on this. We looked high and low for any kind of evidence that there was a difference. And it looks like the reprogramming is complete, right, in response. So it's a great hypothesis. It got me lots of money, but it's wrong. That we don't know.
Dr.
So if you
Lakakis,
can,
go ahead.
thank you. So by blocking interferon gamma with emapalumab, this could improve
Okay, well, why
fibrosis.
don't we read his question?
What if I put up?
Could emapalumab help fibrosis?
What is it?
Emapalumab, the medication that blocks interferon gamma.
What does it target?
Interferon gamma.
Okay, good. All right. Let me ask you another question. So the sheer volume of bronchoscopies that you must have done and the coordination between getting consent signed in the ICU, collecting the samples, bringing him back to the lab, getting him back to whatever you said, 48 hours is more of the clinical pathogen stuff you were looking at. But what sort of operation do you currently have going on now where you have ongoing access to these bronchoscopic materials?
Yeah, thanks for that question, Roy. That's a really good question. And we actually, we have a very different mechanism for this. So we clinically use like I said, we clinically use the BAL, and this was a big culture change in our ICU that took Rich Wondering, 10 years to convince all of our clinicians of the value of using these bronchoscopic samples and to make that part of our culture. Rich also does clinical trials. So a lot of his work is in clinical trials in the ICU, a lot of it focused on rapid diagnostics or antibiotics for the treatment of pneumonia. And when we actually got the script grant, actually has no support for specimen collection. So 0 by the RFA. And so what we did was we told the NIH that we would pay through the clinical trials operation for the collection of the samples, right? And that the sequencing and all the analysis downstream would actually be what the NIH paid for. And that's the way that grant operates. So it was a novel mechanism that we used to actually generate these data.
Wow. Dr. Punjabi, here, let me give you the microphone so you can be heard online.
Scott, great talk. You talked about this multicellular sequential approach to injury where the monocyte-derived macrophage is clearly very critical. Can you imagine, or do you think it's possible to target these steps, particularly the monocyte-derived macrophage, without impairing normal repair? Is that even possible?
Yeah, I think you're asking a question that's really a big question in the field, Narration. Thank you for the question. So the question is, do you have a reparative function of these monocyte-derived macrophages? That's what you're really asking. And in other tissues, absolutely, right? In the skeletal muscle, cardiac muscle, these cells actually come in and they are definitely important for repair. In the lung, we don't have any evidence, nor do we have any evidence that actually the transcriptional program changes. So Bill Jansen has done this work more than we have. What Bill did was he actually took LPS, bleomycin, and flu, and did transcriptional profiling on the monocyte-derived macrophages over time, right, in those 3 models, and compared them. And they're all the same. And they're all the same, and they're same whether at every point in time after the injury. And that's what we've seen as well in patients. So we did a study in patients with long COVID that were in there where we had BAL sampling that was done as part of clinical care. We did single cell on those samples, and we took patients that the fibrosis got better, which was most of them, right? And the few patients that actually went on to get progressive fibrosis and transplant, they looked the same. We couldn't tell the difference. So we haven't seen evidence for reparative function, which begs the question, why the heck are they there, right? What we think is actually important is they're there to seal the wound. In mice, not in humans, they express a lot of junctional proteins, right? So we think actually, and in mice we know, or in mice and humans, 1/2 of your synovium is macrophages in your joints, right? So we know these things, we know they can make a barrier. And so we think they're coming in to actually seal the wound, right? And they're coming in, and once that function is done, they're not there anymore. And that makes sense then why they would promote SCAR.
Translational science at its best. Thank you very, very much, Dr. Budinger.
Thank you.
I want to thank everybody who came here in person. Those online, please check the chat for the QR code for MEC and MOC. Everybody have a great day. Take good care of each other and yourselves.